right, welcome to the FPMRS Fellow webinar series. This is a joint effort between AUGS, SUFU, and SGS, and we are grateful for the support of this endeavor. I'm Lisa Hickman, and I'm the third-year fellow at the Cleveland Clinic, and I will be moderating today's session. Today's webinar, A Case-Based Approach to Understanding the Evidence-Based Management of Fecal Incontinence, will be presented by Dr. Holly Richter. Dr. Richter is the J. Marion Sims Endowed Chair in the Department of Obstetrics and Gynecology at the University of Alabama at Birmingham. She is Professor of Obstetrics and Gynecology, Urology, and Geriatrics, and the Research Director of the Division of Urogynecology and Pelvic Reconstructive Surgery. She is a past president of SGS and currently president-elect of AUGS. Not surprisingly, Dr. Richter has numerous professional and research accolades, including her long-standing leadership with the Urinary Incontinence Treatment Network and Pelvic Floor Disorders Network. She has pioneered much of the research on fecal incontinence, so I can assure you that you are in for a real treat over the next hour. Our esteemed panelists, who have also made significant contributions to the field of fecal incontinence, include Dr. Lily Arya from the University of Pennsylvania and Dr. Halina Zyczynski from UPMC Magee Women's Hospital. The webinar will feature a presentation for 30 to 40 minutes, during which time we will present some clinical cases for discussion between the panelists. We will open the webinar to questions from the audience for the time remaining. In case anyone is watching this for the first time, I'd like to briefly review a few housekeeping items. This webinar is being recorded and live streamed. All participants will be on mute, but please use the Q&A feature of the Zoom webinar to ask any of the speakers questions. We'll try to address as many as we can within the hour. You can use the chat feature if you have any tech issues. AUGS staff will be monitoring the chat and can assist. At the end of the webinar, you will be prompted to complete a brief survey and provide feedback on the session. I also wanted to let everyone know that our next webinar is scheduled for May 1st, Friday at 10:30 a.m. Eastern Time, titled Pelvic Floor Ultrasonography by Dr. Shoberi, Al-Sheikh, and Dr. Weinstein. Please visit the AUGS website to sign up. All right, Dr. Richter, take it away.
Good. All right, so basically what we want to do is start off making sure everybody has kind of the same background with respect to the anatomy and physiology of fecal incontinence. So I'm going to start off the talk with just a few definitions and a little bit of physiology. So the NIDDK defines FI as the accidental passing of solid liquid stool or mucus from the rectum. A more encompassing term, anal incontinence, includes the loss of flatus with or without the loss of liquid and solid stool. And I would say most of the research that you see on accidental bowel leakage or fecal incontinence does mainly deal with fecal incontinence and the loss of solid liquid stool. So we will concentrate on that today. Just as with urinary incontinence, there are three main types of fecal incontinence. Urgency, which is a strong desire to defecate, and incontinence occurs in an effort to retain stool. Passive, where there's a lack of awareness of a need to defecate prior to the incontinence episode. And fecal seepage, which is leakage of stool after a normal evaluation, usually presenting as staining of the undergarments. And I want to put out a shout to my fellow who has identified a fourth phenotype of fecal incontinence, stress fecal incontinence, and we will not discuss that today. As you know, prevalence rates are dependent upon the definition used with the condition. That is, so in the case of fecal incontinence, is it fecal incontinence over the past week, month, year? It depends on the population that is being studied. Is it in young women associated with vaginal delivery, or is it in women in nursing homes? And it certainly depends on the data collection method. That is, whether a validated measure is used or just a question that is made up. On a recent systematic review where fecal incontinence was at least one time per month, the prevalence rates ranged from 8 to about 12% in community-dwelling women. So that's kind of in general what we're looking at. And as you know, many of you know the study led by Nygaard, which evaluated almost 2,000 women, interviewed them in their homes, and did an examination in a mobile unit. And the definition of fecal incontinence for this study was leakage of at least once a month. And you can see that with increasing age, the prevalence ranged from 3% in women aged 20 to 29 up to over 22% in women aged 80 and above. In terms of the fecal continence mechanism, it results from a coordination of functioning anal sphincter complex, intact sensations, as well as reflexes of the anal rectum, rectal compliance, and conscious control of defecation. Additional very important factors include stool consistency and volume of stool. In terms of how continence occurs, if the sigmoid contracts and stool goes from the sigmoid into the rectum can sense as little as 50 cc's of stool. When that stool works its way down to where the anus comes up to the rectum, it may stimulate the rectoanal inhibitory reflex, where the internal anal sphincter relaxes briefly, allowing for sampling of the contents. The external anal sphincter contracts if she's in not in a socially acceptable place in which to empty the rectum. And as the rectum expands with stool, that's when she'll start getting a sense of urgency, usually at about 200 to 300 cc volume of stool. So the continence mechanism consists of the puborectalis muscle, which is a muscle that acts as a sling. Obviously starts at the pubis, comes down around the anal canal, and comes back up to the pubis. And its contraction forms the anal rectal angle. And this is maintained in a tonically contracted state when there's increases in intra-abdominal pressure, such as walking around. Obviously, the puborectalis relaxes during defecation and is responsible for the continence of solid stool. The internal anal sphincter is derived from the inner circular muscle of the rectum. It's a slow twitch, smooth muscle, and the internal anal sphincter confers up to 80% of resting tone of the anal sphincter complex. It is responsible mainly for continence of liquid stool and gas. And if there's dysfunction in the internal anal sphincter, that's usually noted to result in passive fecal incontinence. This muscle is innervated by the superior rectal and hypogastric plexus. The external anal sphincter is under volitional control. It's a striated muscle with slow twitch as well as fast twitch fibers, and confers from about 25 to 30% of the resting tone of the anal sphincter complex. It should be able to contract to at least the doubling of a baseline pressure, and it maintains continence to liquid stool and gas. And dysfunction of the external anal sphincter usually results in symptoms of fecal urgency. The external anal sphincter is mainly innervated by the pudendal nerve. When we look at the anus itself, it goes from the dentate line down to the anal verge. And you can see some of these vascular structures here. These vascular pillars also confer a level of continence to the anal sphincter complex. So we've gone through, this provides a fairly comprehensive list of reasons why a woman may develop fecal incontinence. You know, certain mechanisms of the continence, certain parts of the continence mechanism may fail. Usually there's an adaptability as well as a compensation of other parts of the continence mechanism. And usually when a woman presents to you with fecal incontinence, its cause is multifactorial. So we can think about things on our differential such as abnormalities of the anal sphincter complex, maybe from obstetric anal sphincter injuries. We think about lack of sensation, thinking about maybe there's a problem with the reflexes. We think about rectal compliance. Does she have inflammatory bowel disease that may be contributing to her problem? She's not able to, the rectum is not compliant. Maybe there's a problem with conscious control of defecation, so the mediation centrally is aberrant. And certainly a very important component that we're going to hear about is stool consistency as well as volume. So right now we're going to go on to a case that Dr. Hickman will present for us.
All right, a 33-year-old P3013 presents with a 3-year history of fecal incontinence and anorectal urgency that started after her first delivery and then improved but has worsened recently. She also describes dyspareunia and a gaping feeling. Her obstetric history is notable for 3 vaginal births, the first of which required forceps and per her memory required a lot of stitches. Her last delivery was at the age of 31. She reports alternating constipation and diarrhea. She is obese, but her past medical history is otherwise unremarkable, and she previously had a laparoscopic cholecystectomy. Dr. Arya, what do you see here, and what type of evaluation is indicated?
So as you can see, when you examine her, so in her history, she had many important features. And if you guys all notice that her etiology was very much multifactorial, with having significant obstetric risk factors, diarrhea, constipation, and a history of cholecystectomy, all of which can contribute to fecal incontinence. Now, when you examine her, you can see the signs of the obstetric laceration that she had. She has a gaping anal verge. She has a very short perineal body. You can see that the striations of the anal sphincter are missing anteriorly. And you can, if you look closely, you can see the dimples of the retracted anal sphincters on each side. Let's move to the next slide. So when we look at the, when evaluating this particular patient, it's important to take a good history, and most of us are familiar with the importance of measuring the of asking the patient whether she's losing solid stool, liquid stool, or gas. But it's also very important to assess the associated symptoms, and fecal urgency is of course a common one. But there are some other associated symptoms can be very helpful too, such as a sense of incomplete emptying, which will hint at the compliance problems that Dr. Richter was talking about earlier. And another symptom that I find very useful is loss of anal discrimination, where if a patient is not able to tell the difference between solid stool, liquid stool, and gas, it would suggest neurologic damage. It's important to be able to assess, are there any food triggers, and a food diary is often very helpful for this. There are many standardized questionnaires available, and on the right side of the screen here, you see one which is very simple and easy to use, the VASI score, and it can easily be incorporated into any medical record that measures not only the types of leakage, but also its impact on quality of life and fecal urgency. Next slide. So when we do a physical exam of a patient with fecal incontinence, on the right side, you see the picture of a patient with a classic oasis injury. You see anal patulence, but you very clearly see that there's a very short distance between the vagina and the rectum, suggesting the loss of the perineal body. And here's the dovetail sign, where the anal sphincter has retracted laterally, producing the classic dovetail pattern. An exam should also be focused to detect any coexisting rectocele, to rule out any coexisting recto-vaginal fistula. Especially in older patients, one should carefully seek out a rectal prolapse, and a digital rectal exam is very important in a patient with fecal incontinence, where you would assess first the tone, which will tell you how good the internal anal sphincter is, whereas the squeeze strength tells you, it gives you information on the external sphincter. Relaxation with the Valsalva will give you an idea whether there's any associated pelvic floor dysfunction, which can be a cause of fecal incontinence. And you can detect a rectal mass. Each one of us will pick up at least one case of anorectal cancer in our lifetime. And of course, you may notice fecal impact would be causing overflow fecal incontinence. Next slide, please.
So, Dr. Arya, what diagnostic tests would you obtain for our patient? Obviously, you're going to start with ultrasound, potentially.
Yes, so even though the exam showed clear evidence that likely the anal sphincter is damaged, anal ultrasound can give you additional information. The first of which is to confirm that the external anal sphincter is in fact damaged, but you can also look at the internal anal sphincter, and this helps with surgical planning and assessing the prognosis of the patient. So if you look at the picture on the top right of the screen, that shows you the endoanal ultrasound of an intact sphincter. You can see the the dark ring, which is the internal hypoechoic region, which is the internal anal sphincter, and the outer echogenic ring is the external anal sphincter. And if this image was taken in the proximal part of the anal canal and you were to zoom out, you would see a U-shaped puborectalis muscle, a strap-like muscle somewhere around the 12 o'clock position. In the lower right side of the picture is the endoanal ultrasound of our patient, where you can clearly see the damaged end of the external anal sphincter on each side. And in the central part of the internal anal sphincter, you can see some change in echogenicity, which suggests that internal anal sphincter might also be damaged. Let's go to the next slide.
So in terms of management for this patient, we know that with treatment of fecal incontinence, there is a lack of high-quality RCTs, although there have been a couple more recently. Really, we need more rigorous trials in the various modalities, treatment modalities that we have. And typically, for most women we see, an optimal treatment likely will involve a complex combination between surgical and non-surgical therapies. For this woman, typically we would offer surgical, for any woman, we would offer surgical management after a credible behavioral therapy treatment. However, in this lady, Dr. Arya, would one of these surgical approaches be appropriate?
Yes, so for most patients, one would want to first consider non-surgical treatment, but given the fact that this patient is young, has clear symptoms of perineal dysfunction, including feeling of a gaping anus, gaping perineal region, certainly it would be reasonable to proceed with a sphincteroplasty. Next slide. So then the question is, who is the optimal candidate for anal sphincteroplasty? In general, younger women with fecal incontinence who have poorly healed obstetric anal injury that we have clearly documented. They have severe fecal incontinence, and they have a large defect. So the large defect has to be involving more than one quadrant, so it would be about more than 90-degree defect. And when approaching the sphincteroplasty, it should be with the goal of restoring the sphincter, the anatomy of the perineal body, and restoring function. Next slide. So when doing a sphincteroplasty, it's important to do a curvilinear incision. You do dissect out the sphincter. Now, increasingly, you should be focusing on the internal anal sphincter as well. And if you can see it, you should plicate that, especially in our patient who may have some injury. Identify the external anal sphincters. There's no good data to suggest whether overlapping is any better than end-to-end. But certainly as you're doing the dissection, it's important not to get carried away and do too wide a dissection, because if you go more than 180 degrees, you could potentially injure the pudendal nerves. And it's important to do a perineorrhaphy as well. And if you, there's also a coincident injury of the pubococcygeus, that can also be repaired. Next slide. So this is what, this shows our pre-post repair. On the left side, you can see the gaping introitus and the short perineal body, and you can see on the right side how the anal opening has been tightened, there's a nice long perineal body. And if like levator plication was done, care was taken to make sure that the vagina was not made too narrow. The next slide. So what are the outcomes? So there's Glasgow in 2012 published an excellent systematic review that focused on long-term outcomes. And in this study, they measured patients as having good outcome. Now, good outcome was as reported by the various studies. And of course, what was good was vague and kind of different in each study. And as you look at this graph, you'll see that the rates are pretty good immediately after surgery. But if you come to the 60-month mark, majority of the studies end there. And after that, these good outcomes start declining. And the only study that went out to 10 years, the one you see down by 120 months, unfortunately, in that study, not a single patient remained continent at that time. Next slide. So in general, majority of the studies are retrospective. They report that there's a good efficacy of sphincteroplasty in the short term of 70 to 80% improvement, but it begins to deteriorate over time, reaching 20 to 60% at 5 years, and then almost 0 to 40% at 10 years. But you have to recognize the fact that majority of these studies are retrospective. They did not stratify patients by age, like were younger patients, do younger patients with sphincteroplasty have better outcomes? We don't know that. The next slide. So in summary, approximately 2/3 of patients will report short-term improvement with sphincteroplasty. Most of this is based on patient recall with little prospective data. Majority of the studies have not used standardized outcomes. And people have attempted looking at a variety of predictors, and no predictor has been consistently been shown to predict outcomes of sphincteroplasty. However, for young women who have a clearly documented obstetric anal injury, a sphincteroplasty would be a good first choice with the goal of restoring the sphincter to a circumferential configuration, which you can check in the post-op period with an endoanal ultrasound, though an MRI might suggest that you have not necessarily restored the muscle sphincter and you might actually simply be looking at scar tissue. But, and the most common complications are wound infection ranging from 2 to 35%. The next slide.
Okay, so now we're going to fast forward 25 years. Our patient did well for several years. However, over the past 3 years, she has noted increased difficulty controlling gas and strong fecal urgency with fecal incontinence. She has an accident at least 1 time per week and wears pads to be safe. She keeps extra clothes in the car, and she had a recent accident while shopping. Dr. Zyczynski, what would you think about doing for the patient at this point? Obviously, you'd go through her history and physical exam, but then what?
Right. So you do start from scratch. Do not assume, you may not even have had the luxury of knowing her 25 years earlier. There are some characteristics about her that really do predispose to this vulnerability of fecal incontinence. We heard from you, she's obese. She cycled between constipation and diarrhea. There may be an IBS component. She had a cholecystectomy. All of these are certainly risk factors. We need to start from scratch again in terms of first line treatments. She may have gone through physical therapy the first time after her sphincteroplasty or between delivery and her sphincteroplasty, but certainly the opportunity should be afforded her to relearn how to coordinate those muscles and strengthen them. And I would think the keystone of everyone's intervention is also taking a critical look at her diary, her intake of her choices of foods and fluids, fats. At this point, she may be a diabetic. There may be some oral agents to take into consideration. We're here. I'm going to advance my slide too. Sorry. Just looking at the Bristol stool scale and recognizing that we need to learn what her stool consistency is like. a core element of behavioral modification is normalizing stool consistency. In almost all of the studies we've looked at first and second line treatment for fecal incontinence, unformed liquid or soft stool is a predisposing risk factor for the control or the storage of that stool. And you can obviously impact, advise, and guide on stool consistency by eliminating irritants that you identify, the rapid transit time of the gut that's associated with caffeine intake. We're looking at the other medications like the hypoglycemic agents. You need to advise her, if she can, to adopt patterns that would allow her to ritualize her bowel movements. Ideally, have a bowel movement first thing in the morning. If she has stool trapping, consider some type of lower rectal irrigation with an enema. I think we can advance the slide. Obviously, fiber is a key element to influencing stool consistency. It's paradoxical that we use fiber as providers, both for constipation at one extreme and then fecal incontinence or too soft and pasty stool at the other extreme. You do have the advantage with fiber of either having, I've heard people describe, Catherine Matthews especially, wet fiber and dry fiber. Somebody has, softer, more pasty stool, consider smaller volumes that you're dissolving your fiber bulking in as compared to somebody who's constipated where you want to moisturize or hydrate the stool, enhance the amount that they're drinking. There's also slowing down the gut with loperamide. And as I was saying to Dr. Richter and Dr. Arya before we started this, if I had to have one tool in my toolbox for fecal incontinence, it would actually be cholestyramine. I think that has been a very valuable tool for managing particularly obese patients who have a little bit of IBS and then are managing also their fat intolerance, their bile salt diarrhea, if you will. So you should keep that in mind. It is an off-label indication. Muscle strengthening is key. Women lose, if you will, connectivity to the muscles of the pelvic floor. We recognize that with urinary incontinence and so many other dysfunctions. If they can connect to a physical therapist, I would advise them to.
If they're hungry, they want to eat.
Somebody's
by 5-ish and then do the yoga now, and then I want to go food shopping.
Sure.
Somebody's taking yoga classes. Okay. In any event, getting a personal trainer for your pelvic floor to rediscover those muscles and strengthen them would be key. Part of physical therapy also includes that recognition of rectal sensation. And there are ways of working, whether with manometry or without, on just awareness and sensation of stool descending into that lower rectum, the coordination of muscles, using every pelvic muscle you have access to in neuromuscular efforts to retain the bulked up solid stool would be the approach that I would take. Moving forward, we think it's key for all fellows to be aware of the Capable study, which was a 2x2 factorial design, a randomized trial that looked at first-line interventions, seeking some insights into whether loperamide, physical therapy, pelvic muscle strengthening with biofeedback, and sensory awareness with manometry was helpful. The St. Mark's score, as you will read in Lancet, was the primary outcome. Although there were no differences found between each of the intervention trials, it's important to recognize as you take a deeper dive in the outcomes, that one of the common outcomes that's used certainly in neuromodulation studies is that landmark of 50% improvement in fecal incontinence episodes. And though you can see here in the slide that the St. Mark's scores did not differ between groups, there was a really impressive impact of, if you will, the placebo education, which was supposed to be the non-intervention arm. 58% of women actually had a greater than 50% improvement in fecal incontinence episodes just with the placebo as compared to loperamide and an educational pamphlet. So the diary, introspection, review, guidance, and advice for behavioral modification, dietary intake, all play a role in improving symptoms. This is a study you definitely need to know about. It's going to be on your everything from your creogs for the residents on, all the way through your your licensing exam. We do have this slide up here to talk a little bit about manometry. I personally don't use manometry in guiding me to treatment, quite frankly, because as you know, whether we identify denervation or fibrosis, at this point, there's not a lot we can unfortunately do about those discoveries. However, in the research arena, and as we're trying to sort through predictors of success, anal manometry will certainly provide some insight in that radiation proctitis, the non-distending or asensate rectum or colon. Moving on to our next slide.
Dr. Richter, what other non-surgical approaches are available for our patient? Would you mind going through some of these?
Sure. First off, great description of the surgical approach for anal sphincteroplasty, Lily and Halina. Very nice behavioral management approach to this woman. So she's in a situation where she's had a previous anal sphincteroplasty and she's doing behavioral therapy. What other non-surgical and device approaches exist? As many of you know, there are anal plugs. PTNS is being studied in the US. It is actually being performed in Europe. We have the vaginal bowel control system, as well as perianal bulking available and radiofrequency ablation. So let's look at these real quickly. So when we think of the anal plug, the most popular one is the Renew insert. Mimi Lucas led a study out at UCSD looking at 97 women that had a fairly impacted history, a Wexner score greater than 12, and they had weekly fecal incontinence episodes. And 80% completed 12 weeks of treatment where they had a significant decrease in fecal incontinence episodes per day and a significant decrease in the Wexner score. However, a lot of women have some urgency and irritation as this plastic prong goes through the anal canal. It can cause some irritation. There is a new device as well under study. I think there's an Israeli company studying this called the Forcanti. As you can see, it's placed up into the anal canal with the use of a device very similar to a tampon. And as you can see in the second picture, the part that holds back stool, the plug is actually above the dentate line. So the irritation is markedly reduced as compared to the Renew. And we're still awaiting some data on this type of plug. PTNS is still investigational in the US. It's performed exactly as we would do for refractory urgency urinary incontinence, the use of a 34-gauge needle. It's minimally invasive, has minimal morbidity. It's certainly less expensive than sacral neuromodulation. But many people would say having to go every week for 12 weeks is fairly burdensome. There is, and remarkably, even though it's being used in Europe, there are 2 trials that were performed there where there was no difference in active therapy compared to sham. We actually talked to Dr. Knowles in Great Britain regarding the study, and his patient population was a little bit different than the population we deal with as urogynecologists. And based on this, Dr. Zyczynski led a trial through the PFDN looking at neuromodulation for accidental bowel leakage. This is a randomized trial of active PTNS versus sham, and we will have the results of this trial very soon. Many of you may know about the vaginal bowel control system. This is a system that was actually designed by students doing a biodesign engineering course at Stanford. And these guys were tasked with a question of finding an unmet need in terms of some medical condition. And on talking to doctors, they found that fecal incontinence still had a lot to be desired with respect to effective treatment modalities. So they designed essentially what looks like a pessary. It goes into the vagina. It's a stainless steel ring, silicone coated with a posterior deflected balloon that, when pumped up, deflects the rectovaginal septum in order to block the passage of stool. We've done a couple studies on this. The LIFE study was the first study to show efficacy and looked at adverse events. And over 80% of women had a 50% reduction in fecal incontinence symptoms. And almost 20% of these women actually had cure of their fecal incontinence. This was a short-term study, followed by a longer-term study with a primary outcome at 3 months, and then continued follow-up at 6 and 12 months. And again, in those women successfully fit, over 80% had a 50% reduction in fecal incontinence episodes. And again, similarly as with the LIFE study, continence rates were about 20%. Perianal bulking agents exist, dextraner microspheres and sodium hyaluronic acid. You may know this as Celesta. It was approved in 2001. It's done in the office. There is randomized trial data by Graph, and there's some more recent longer-term data that I think that was submitted to AUGS, so we may hear some more long-term data on the use of the perianal bulking agents. Radiofrequency ablation, or SECA, is a modality that's used really not by urogynes all that much, occasionally by colorectal surgeons, although I think this modality is decreasing. It's an anoscope with electrodes that are placed into the anal canal, and radiofrequency energy is used, is put into the submucosa of the internal anal sphincter. And this causes tissue fibrosis and scarring. So essentially scarring of the anal canal to increase resistance of the passage of stool.
So our patient tried a credible behavioral therapy, but is still having symptoms and would like to pursue surgery. Dr. Arya, what would you recommend at this point?
So there are other surgical procedures that we could consider for someone who has failed conservative management. And, we see various things listed here, but the one that would seem most promising would be sacral neuromodulation. And so let's talk about that. SNS was approved for fecal incontinence by the FDA in 2011. And the technique used is the same as for urinary incontinence, in which the lead is placed in the S3 foramen and then connected to a pacemaker. And quite a few studies have been done to understand the possible mechanisms through which SNS might work. And these have used techniques such as anorectal manometry and ultrasound to and these show that SNS might actually reduce colonic activity and change the rectal sensitivity via the somatovisceral reflex pathway. And the advantage of understanding how the SNS works, also there's a broader advantage to it because it'll help us understand how fecal incontinence happens. And so the fact that the SNS change, that responders show reduced colonic activity, suggests that colonic activity and rectal sensitivity play an important role in fecal incontinence. SNS may actually even directly improve the tone of the external anal sphincter, and it can change the afferent nerve modulation, which would be a mechanism very similar to what happens in urinary incontinence. Next slide. So the indication is obviously for those who have failed conservative measures. An important study was done that showed that SNS works for patients who have been in the presence of a disrupted anal sphincter and for patients who have failed anal sphincteroplasty. Because many patients with fecal incontinence are young, there's been quite a few papers published on whether SNS is safe in pregnancy or not. And there are, it seems that for women who get pregnant after SNS, the SNS seem to be working quite well, even though women had more than one pregnancy. Majority of the women also went on to have, actually majority were delivered by cesarean section because the SNS was in place, but I suspect that was more to prevent any additional injury to the anal sphincter. And however, currently, the International Continence Society recommends that an SNS should not be placed during pregnancy. And also, if one already has an SNS in place, it should be turned off during pregnancy unless we have more data about its safety in pregnancy. Next slide. So efficacy. The short-term efficacy rates have been quoted to be 80% that seem to extend to a 12 to 36 month range with even promising long-term efficacy. But the important thing to recognize is that the SNS folks essentially changed the definition of success to 50% improvement in episodes of fecal incontinence. And the systematic review paper that I was earlier talking about for outcomes of anal sphincteroplasty, the authors of that paper commented that if this definition of 50% improvement of incontinence were to be applied to anal sphincteroplasty, very likely the success rates for sphincteroplasty would be higher than what is currently reported. The common adverse events of, say, SNS can be implant site pain and paresthesia with an explant rate of 3 to 4% and a low infection rate. That's it. Next slide. So do you want to go over the other surgeries, Halina?
Maybe Dr. Zyczynski, would you mind just briefly touching on these? We actually are having a pretty active number of questions coming in on the chat, so I want to make sure we can still get a chance.
Yeah. So in the interest of time, by the time you get to these third tier interventions, clearly fecal incontinence is eroding at quality of life. And women are fairly despondent. For the severe cases, the focus either is in augmenting the sphincter, you could see here in gracilloplasties, artificial sphincters, or in diverting the stool. These tend to be frequently done in the case of diverting stool by the colon and rectal surgery peers that we collaborate with. Unfortunately, some of the more current or innovative approaches to augmenting the sphincter are not currently available to us broadly, and gracilloplasty, although not experimental, has had really very little outcome data published, in any large series. I think what we're going to move to is the new direction or novel approaches, which are less surgery oriented, although they are procedures, and are more focused on stem cell research. Again, there's such a pattern, a parallel with urinary incontinence. The newest research seems to be focusing on a variety of stem cell interventions. Our colleagues in regenerative medicine are looking to both bulk up as well as enhance the function of the sphincter. It is hoped there are some ongoing studies. These have all been small. You can see some of the outcomes have been set at a very modest rate of 30% reduction in Wexner scores. But it is something that we're all looking forward to in the future. I think in light of the 10 minutes that we have left, we may want to wrap up and address some of the questions.
Yeah, thanks, Halina. So what we were hoping to do today for the fellows, it was to try and impress on you that this is a condition that really impacts quality of life and is often multifactorial in cause. Rarely will a single treatment guarantee perfect outcomes. Rarely will multiple treatments result in perfect outcomes. I think if there's an evident indication such that as in a younger woman, an anal sphincteroplasty may be indicated, particularly in the setting of obstetric anal sphincter injury. Behavioral modifications, pelvic floor muscle therapy, medications are all our first line, and you want to send your patient to somebody who does a credible job with this. SNS is a proven approach to the management of FI, and I think many of our sacral nerve stim patients that have had FI that has been improved or cured by InterStim are probably one of the most happy people that we have in our practices. And as you can see, there are many new surgical innovations, non-surgical innovations, but we really need some increased quality and comparative effectiveness trials, which we hope that you, the fellows now and the practitioners in the future, will be able to do. So we'll close with this is what we hold. This is at UAB. This is what we put. No, I'm kidding. So this is a very serious condition. Thank you for understanding the initial blurb in our presentation, and we look forward to talking with you further.
All right, Dr. Richter, Dr. Arya, Dr. Zyczynski, thank you for a wonderful presentation. We have about 10 minutes left to answer as many questions as we possibly can. So I wanted to start out by posing to the panel when you engage a multidisciplinary team. So some of the questions around when you'd get colorectal involved, GI, a nutritionist, etc.
You know, I would say you should be thinking along those lines from the very beginning. Getting dietary, especially involved, a nutritionist, if available to the patient. She would certainly benefit from that early on. As Halina has said, dietary manipulation is a big factor. Certainly, if you're in doubt at all about colorectal causes, that would help. Many of these patients have associated defecatory symptoms. Getting a gastroenterologist involved, especially when they have sensation of incomplete defecation, would be important. So the sooner done, the better.
Great.
Agree.
The gastroenterologist can also help with screening on colonoscopies if there's any concern about some type of a colonic disorder or precancerous, premalignant disorder. I also use GI often for the advanced IBS patients, especially IBS-C, where it's an overflow incontinence, or they're spending so much time working with laxatives that they're having trouble controlling as they're managing their constipation, the inevitable diarrhea. Colon and rectal surgery is really for the complex reconstructions. They're very happy to have us manage the behavior, the diet, the diary review.
Yeah, same with us, Halina. Our colorectal surgeons send us all the fecal incontinence, so anything associated with that. If we happen to have a patient that comes in with a rectal prolapse, we can do joint cases with them. I echo the sentiments with regard to really partnering with a good behavioral therapy specialist, our gastro people, and a physical therapist. But you want to send them to somebody that has experience in dealing with women with FI, because they have to be very patient, and the patients can take time to deal with.
Great. Some of the other questions from the attendees would like more of a discussion of how you decide between sacral neuromodulation versus sphincteroplasty, for example, in a patient who maybe is further out in her life, if you'd still consider a sphincteroplasty versus if they don't have any kind of sphincter defect, would you lean towards sacral neuromodulation?
Yeah, so that is a very good question, something that we all struggle with. So the patient that we discussed had a clear, obvious anal sphincter defect, and for those, she is the classic patient for whom a sphincteroplasty would be appropriate. Certainly, we should not be attempting sphincteroplasties on patients who have an intact sphincter. So that's a no-brainer. Certainly, you wouldn't try sphincteroplasty from that point of view. The complex patient is an older patient who does have anal sphincter defects, and the question is, should you do sphincteroplasty on her or not? Again, the older the patient, the less likely I am to do a sphincteroplasty because age seems to be a bit of a prognostic factor, I often use other coincidental findings to decide whether I will do some kind of surgery on her or not. If she has a good big rectocele, if she has obvious perineal defects. So those things will lean me towards trying to do a sphincteroplasty first. But in general, for older patients who have tried a lot of behavioral treatment and have not responded, I would lean more towards sacral neuromodulation. I don't know what Holly or Halina would like.
Yeah. I would say I've really evolved on that over the years, Lily. I agree with you. First off, if they're 30, 40 years from a sphincter tear, you know, you're going to be doing some mobilization that's could potentially cause more injury in order to try and identify sphincter ends. And by this time, it really takes a lot of work for them to relearn how to contract that muscle. The pelvic floor therapy is probably more important than putting the sphincter ends together. And I've just evolved over the past decade and a half, a decade or so, and I really do, when I see they're in their late 50s, 60s, even if they have a sphincter tear, and if they have completed a credible behavioral therapy program, I would tend to go toward SNS as well.
I agree with you. I think it's been a humbling experience. In the 80s, 90s, early 2000s, we certainly were doing far more sphincteroplasties for the patients even in their 50s, 60s, and 70s. And as we have identified the diminishing returns and the morbidity as the patients are older, diabetic, hypertensive, obese, the morbidity of an up to 35% infection rate is really difficult. It's not to say that I don't offer reconstruction for women who have never had the opportunity, or international patients who have not had the opportunity to have the complete disruption of their perineal body addressed. So we will embark upon reconstructive procedures that are pretty extensive, not exclusively for the promise of fecal continence, as much as that global aesthetic body image, sexual dysfunction. There's got to be more to that outcome that I feel confident I can, you know, not promise them, but likely afford them. It's not going to be for the fecal continence. So we move towards sacral modulation in that group also. Not mentioned, which is a very simple, super cheap intervention. I know we talked about anal plugs, but our Arnie Wald, who was a gastroenterologist who spent a lot of time in fecal incontinence in the 80s and 90s doing research, taught me early on a triple size cotton ball to use as a rectal plug, or in many ways a rectal tampon, for the mild seepage hygiene issues, sort of that combination of hemorrhoids or previous hemorrhoidectomy. That difficult hygiene situation is a pretty effective, very cheap intervention that anyone can adopt.
Maybe just very briefly, since we're running out of time, any role for defecography in your opinion?
So again, I find that defecography rarely changes my plan of management. The defecography is probably most useful for the patient who has a lot of associated defecatory symptoms, especially sense of incomplete emptying, where you think that there might be an enterocele contributing to it. What I generally find is that the kind of enterocele that you think is contributing, you can generally see clinically without necessarily having to do a defecography. We all deal with patients walking over from the gastroenterologist's office with a defecogram report on the hand showing a rectocele or an enterocele, which you can barely see clinically. And they are hoping that you can do something surgical about it, but it's difficult to fix something surgically that you can't see. So I tend not to do too many defecograms. I don't know what Holly and Halina do.
Yeah, so I've done more defecography recently than I've ever done, but it's not for FI. It's for more obstructive defecatory symptoms, to rule out intussusceptions, internal rectal prolapse, those types of things. So, and I certainly don't use it to try and find an enteroceal or a rectoceal as some people, mainly gastro kind of people, send their patients for these kinds of evaluations. But overall, I agree, Lily.
I have nothing else to add. I agree with everyone.
All right. And what about the role of a rectoceal repair in fecal incontinence? And maybe we'll leave that as our last question.
Yeah. So when there's stool trapping in that rectoceal and you can document it, and that is a potential role for defecography, although again, like Holly and Lily, if you can't see that rectoceal, the radiologic depiction of it is not going to help. But in those clinically overt rectoceals where there's likely stool trapping with a post-defecation sort of remote oozing or persistent drainage, the potential to address that reservoir of trapped stool might be helpful. But I've more often found in those patients that if you can dry up their stool, bulk up their stool, normalizing it so that you can get a clean evacuation, it also addresses their symptoms.
All right, great. Thanks, Dr. Zyczynski. Thank you to our wonderful panelists. Unfortunately, we are out of time. This has been a fascinating discussion, and I'm so glad that we're able to answer the questions from the audience in the time we had remaining. I'd also like to once again thank AUGS, SGS, and SUFU for putting together these informative webinars during this difficult time. Just a reminder that these webinars are every Tuesday and Friday for FPMRS fellows and others who would like to join in on this great educational experience. The next webinar will be held this Friday, May 1st at 10:30 a.m. Eastern Time. We look forward to seeing each of you then. If you can't watch the live broadcast, you can also watch the archived version of on the Society's websites or find it on YouTube if you search AUGS Fellow Lectures. See you next time and stay well.
Thank you.